What we know in terms of a person's brain when they suffer a brain injury and when they're in a coma, and the rates of like a full recovery versus, just sort of like what we know in terms of what's going on in their brain initially.
Right. Well, the brain recovers in a number of stages, and it's important that we don't sort of argue about what's going to happen at the end, at the beginning, and try to give families incremental information as the situation progresses. So people who are, have a severe brain injury will lose consciousness. They'll be in a coma, which lasts for a couple of weeks, and it's an eyes closed state, and then their eyes will open, and that reflects the recovery of the lower part of the brain called the brainstem, which controls your automatic activities, your breathing, your respiration, as it were, and then from there they move into what's called the minimally conscious state, where they're often confused with being vegetative, often at high rates, up to 30–40% confused with the vegetative state, but those people are conscious. People who are permanently vegetative, though, are never going to recover. It's important to say that. But once people get to be in the minimally conscious state, it's unclear who's going to recover more fluent and expressive communication. And that's work that we're trying to figure out, is how do we understand which of these patients are going to get better, and how do we accelerate their recoveries and augment and foster their recoveries. There was a recent study from an investigative team with a large database of patients that something like 23% of patients with a really severe brain injury, like a Glasgow Coma Scale of 3, which means that if it was any lower, you would have died. These people will gain recovery to the level they're able to live independently. And I think that number is a lot higher than most people assume. So we're kind of in a tough spot because, there are people who will never get better, people like in the Terry Schiavo or Cruzan or Karen and Quinlan, but there are people who look just like her, who are not vegetative, they're minimally conscious, and they have some possibility of recovering.
What does that minimally conscious state look like?
These are people who are often confused with being vegetative, but they have intention, attention, memory. They'll track somebody in the room, they'll grasp for a cup of water, they might even, their eyes are open, and they might actually say something, but they don't do it consistently. So when you bring the doctor back in to show him, hey, Joe is doing this, he's not doing it anymore, and that leads the docs to disbelieve it. And the question is it wishful thinking, or did it really happen? So we have to be very careful to give people the right kind of assessment, because the diagnostic error rates are quite high. And a lot of times people end up in nursing homes where they come with a diagnosis, right? And it's hard for the nursing home doc who sees the patient once a week, who maybe is not as expert as the doctor at the medical center, to counter the diagnosis that the patient was given when they left. They might have been vegetative when they left, but they weren't permanently vegetative. And they moved into becoming minimally conscious at the nursing home, and the doctor at the nursing home says, well, they can't possibly be doing this because they're vegetative. If somebody's diabetic, they come from the hospital, they go to the nursing home, they've still got diabetes. But these are not diagnoses, these are states, and these states can change. So we have to have more diagnostic vigilance and care for patients in these facilities, and they're usually underserved, and therefore they're often misdiagnosed. And what we're talking about, to me, is a moral question, that we're treating people who are conscious as if they're not. And I think it's a moral obligation to identify consciousness, and consciousness really is a civil right. If you're conscious, you deserve it to be recognized, maximized, so we can bring you back into the nexus of your loving family and your community.
So you talked today about a few examples of people who'd been, thought that they were in vegetative state forever, and then they woke up and spoke. Right. So what do we know about the time frame of how the brain recovers?
Here, this is a great question. Horrible answer. In most of medicine, the longer you're sick, the worse it's going to be, right? The longer you've got an intractable disease, the less likely you are to survive. But once you get to the minimally conscious state, they say there's no time coefficient for that, right? So the longer you're in MCS doesn't mean you're less likely to improve. And if you remember what I said during the talk, if you have networks that are intact, if you have that highway system that's intact, right, it's always there. It's always potentially there to be driven on. You just have to drive the cars on it. How do you make that transition possible? And what we've been looking at are drugs, devices, and short of that, If they don't have behavioral outputs, how do we tap into it using the neuroimaging?
So, I mean, how would you say, and I know this varies from hospital to hospital, physician to physician, but how would you say overall neurology is being practiced now in terms of people who are in this vegetative state, have this,
Not vegetative state.
Or the minimally conscious state.
Right.
And I'm curious about like kind of where we are in terms of recognizing that and where you think we could be in 5-10 years down the road.
It's not a question necessarily for neurology, because most people have left the places where there are neurologists. They're in chronic care facilities, but they're not getting the rehabilitation that they need. And they're not getting access to the experts in rehabilitation, physiatry, neuropsychology, speech pathology, speech therapy that might actually help them recover and demonstrate that they're there. I know of a recent case of a patient who had brain injury who wasn't able to see a speech therapist, and a speech therapist did the simple task of just touching their lip to get their speech moving. And all of a sudden they're talking. The game is different, right? All of a sudden they're a talking patient who needs care versus somebody who was presumed to be unable to be responsive. So we need to, provide better resources. And in fact, in the Affordable Care Act, in the initial iteration, there was no provision for rehabilitation. And Pia Carusone, who was the chief of staff to Gabby Giffords, the woman, the congresswoman from Arizona who had been injured, wrote a letter to the Secretary of Health and Human Services saying we got to include rehabilitation.
And how much is known about, like, in terms of, if like I'm 27 and I get in a car accident and have a traumatic brain injury versus if my mother or father or my dad, who's 57, he has the same injury. How much is known?
Old, huh?
No, it's not old, but it's a 30-year difference.
I'm just joking.
Versus my grandma who's in her 80s. Yeah. Like, what's known about the differences and how the brain could recover?
I mean, age is a prognostic factor. So the younger you are, the better you probably do. In part because when you get older, you have also the diseases of aging. So you might have early cognitive decline and the like. But certainly the place where that really matters, and since we're at a children's hospital, where it really matters is in kids, because the kids have a developing brain. So kids that have brain injury have the benefit of brains that are still coming online and developing and sprouting new connections and making new areas of the brain. And so there are often workarounds the brain does. So it's much harder to prognosticate for a kid because they have the benefit of the developmental process. And then younger people do better than older people because they have other coexisting diseases as well, potentially.
Probably my last question would be, when you're in that situation as a family member where you have somebody who has had a terrible injury, you're usually not, it's like all the decisions are coming very quickly. What would you say to family members who are, going to read this and think like, oh my gosh, could I have done more for my loved one? Or, oh my gosh, what if this happened to my loved one? What would you say in terms of like the questions that people need to be asking and like the types of, because you don't want to give people false hope, but at the same time you want people to feel like they're making an informed decision.
Right. Well, this is why I wrote my book. It's called Rights Come to Mind, Brain Injury Ethics and the Struggle for Consciousness. We published in August by Cambridge University Press. And, I spoke to some 50 families who come to our program for these studies to ask them that question. What would you have done differently? How would you think about it? And I think the most important thing is, one, not to berate yourself for the best decisions you made when you made them, because, Kierkegaard said life is lived forward, it's understood backwards. You can only do what you can do in the moment. But I think for families that are going to confront these problems, I think it's important to ask questions, to be informed, and to ask about prognosis and to get good opinions. And it is a balance between false hope and real hope, and hopefully the scientific community will give doctors more information so that we can better help families either reach closure when there isn't the prospect of recovery, or the optimism to move forward when there may be hopes for more recovery than might be apparent at the beginning. But I think time is really important. Sometimes letting things play out a little bit, not forever, but a little bit, will give you more prognostic information. Again, it's that hurricane image I put up on the screen. You might be able to tell where you're going by having the hurricane come a little bit closer to shore And to make a prognosis at the very first day about where somebody might be a year later is a lot harder than waiting a few weeks, because people declare themselves and you might have a better sense of where the situation is headed. So time, good questions, and for those families that have been touched by severe brain injury, I don't want them to hear this and say, I wish it had been otherwise. I wish I had known this then, because you can only do the best you can when you're in the moment. And there really can't be second guessing, because that's not the purpose of this.
I lied. I have one more question. Especially for this hospital, they're going to see people who come in and maybe they've fallen and only hit their head, like say they, and so that's their only injury, the rest of their physical body. And then they're also going to see people who have a severe head injury but also been in a car accident, so they've got a broken leg and a bunch of broken ribs and their whole body's just angry. Is there any much research in terms of how the people who have the lots of bodily injuries versus the people who just have the head injury, in terms of recovery there? Is there much known about differences or similarities?
One of the challenges with brain injury, it's often invisible. Mm-hmm. And people look and say, that person looks perfectly fine, but they're having lots of struggles. And maybe paradoxical that if you have some other kind of coincident injury, that people will see that you've had a serious injury. But it's, brain injury described as a silent epidemic. These people are often invisible because their injuries are internal, and you only see it when you get to know somebody a little better. But I think we need a lot of brain education. We need a lot of science literacy, and we have to reach out to the community and talk about brain injury. I can't tell you how many talks that I give around the country where somebody will come up to me and say, my dad, my cousin, my sister had a brain injury, and we don't really talk about it. And I think it's one of those things that is part of our lives, and we have to talk about it. And right now, too often we put these people away, far away from us, because we're terrified of it. And they're segregated from the rest of us. And we have to bring them back in, let them benefit from all the neuroscience that we're learning about, and let's try to bring them back into the communities and allow them to love and be loved, because many of them retain that capability, and we shouldn't deprive them of that human community.